All right. So thank you, everybody, for joining us. We are really excited to have some speakers with us this afternoon to talk about the ins and outs. So we have some great speakers talking about swallowing, about GI, and a little bit about GU. I will share that you get a special guest speaker today, and Dr. Maina Scavina, who is standing in for Dr. Dan Wood, who is going to talk on GU, but due to some travel difficulties was not able to join us. But, you know, Dr. Scavina is pretty spectacular, so you're in for a treat. Dr. Richard Schell is a pulmonologist, but he's just one of our favorite friends and does a great job at moderating, quite frankly. So I think that we're in for, like I said, a real treat with this group. And with that, I'm going to hand it over to you, Dr. Schell, to introduce everybody and get started.
All right. Do we need to? I don't know. So welcome back to the afternoon session. I'm Richard Schell. As Rachel said, I'm a pulmonologist, so I'm here to talk, or at least moderate, peeing, pooping, and eating this afternoon. So all things that we hopefully do very well, but I think there's a lot of information that we can talk about, especially some of the concerns we have in all of our specialties. So I think that how I kind of envision this is that I'm going to, I also feel like I'm talking very loud. I'm going to let everybody introduce themselves, and each of our panelists here have a few slides to kind of like hit some of the most important points that they thought we should not miss. And then we have some questions for the group, and then we'll open it up for everybody else as well. So with that, I believe we're starting with swallowing. Eating.
We'll start at the top.
Yeah, exactly.
Hello, everybody. Thank you for bearing with us and being here this afternoon. I'm Kiera Berggren. I'm a speech-language pathologist at Virginia Commonwealth University. And I have loved the opportunity to work with PPMD. I'm pretty passionate about swallowing and swallow safety. Happy to answer any questions. I'm super informal, so please just grab me if you need anything. And somewhere up here. Oh, okay. So what is dysphagia? That's just a really fancy word for swallowing difficulties. And when I think about swallowing, I think about, is it a problem with the mouth? Is it a problem in the throat? Is it a problem in the esophagus? It can be one or all of those. And in Duchenne, the prevalence is about a third. In the literature, about a third of individuals with Duchenne may have some dysphagia. And I think, especially now that we're seeing our young men get older and older and older, yay with all the therapies out there, I think there may be an increasing prevalence as we get a little bit older. And this can be impacted as well, or swallowing safety can be impacted as well by respiratory function. So I work really closely with our pulmonologists as well to help coordinate that breathing and swallowing, because they're pretty tightly linked. And if there's a problem in one, there can be a problem in the other. So if you or somebody you love has some swallowing difficulties, speech therapy is your go-to. Our job is to get in there and kind of just evaluate swallowing. There's a bunch of different ways we can do that, different types of assessments that we can do. And I really try and make it very personal and very personalized and very individualized. So I'll work with the individual to identify the goals that they may have, and their goals, not necessarily the family's goals, but the patient's individual goals regarding eating and nutrition, and recommend strategies for them. I'm the last person, and I tell all my patients this, I'm never gonna tell you you can't eat X, Y, or Z. I want you to eat. I want you to enjoy eating. I want you to be as safe as possible about it. So, maybe some strategies to help you be a little bit safer when you're eating. So I wanted to throw in a few kind of quick tips on swallowing and eating safely. This is not meant to be if you have swallowing difficulties, do these things and you're going to be cured kind of thing, but just some suggestions that pop up pretty frequently for me with my individuals with Duchenne. So shorter meal times so that we're kind of limiting fatigue over the course of a meal. Taking small bites and small sips, that's really hard if it's like a big hunk of chocolate cake for me, but I try, really. You can consider some sort of adaptive utensils, things like nosy cups or using straws. Again, very individualized. Some people do well with these, some people may have more difficulty with them. I think one of the bigger things I see in Duchenne is posture, being upright when eating. If you have some scoliosis or sort of weak trunk muscles, that can be a little bit more challenging. So maybe some supportive help with that. And I often will work closely with the PTs in our clinic to help sort of brainstorm best ways to do that. And I always think of foods kind of on this continuum of complexity, and later in the day when we're all a little more tired, having softer, more moist foods might be a little bit easier. I was really excited to see the mac and cheese bar last night. I know I'm kind of goofy that way, but softer, easier to eat when we're all kind of tuckered out. So, and really my overall goal is to minimize the risk of aspiration. I want to keep those lungs healthy for the people that I work with. Making sure that we individualize strategies for them and really honoring their goals around eating and nutrition. Sometimes this may involve somebody choosing to get a feeding tube. It's absolutely a choice. Some people go that direction, some people don't. And I tell people I'm happy to support whatever you would like. I always like to remind people that it's not an either-or proposition. If you choose to get a feeding tube, you can still eat by mouth. It takes the pressure off eating. You can get a lot of the calories to support you via the feeding tube, and then enjoy as much chocolate cake or milkshakes or whatever it is your goal is that you enjoy eating. So. With that, I'm going to turn it over to the next people and look forward to questions. Thank you.
I just, to add some 2 cents to that too, I think that from a medical standpoint, we're talking about bulbar function. So there's tons of muscles that are affected, and we're all trying to put a definition on this too, but bulbar function isn't just swallowing. Bulbar function is speech. Bulbar function is protecting your airway so food doesn't go down. I think in Duchenne it's very interesting to me, and many of the neurologists that I work with who have taken care of patients with Duchenne Becker for their entire careers can't really explain to me why in Duchenne muscular dystrophy we don't see a lot of aspiration, but we see more problems with chewing and getting the food from the front of your mouth to the back of your mouth so that you can easily swallow it. And I think there's a big distinction that we have to think about, because I think that adds into what Dr. Williams is going to talk about next in a way, because you have to get that food to the right spot so you can swallow, and that affects your nutrition, and everything kind of runs together. So I'll let Dr. Williams introduce himself and talk a little bit about GI.
Okay. I just need some help here. All right, hi, I'm Dr. Williams. I see I forgot to put my name on the slides. Maybe I don't want to take credit for it. But anyway, I'm a pediatric gastroenterologist. Been working with Duchenne's for quite a few years now. And I'd have to say how I approach a Duchenne patient now is very different than how I did when I first started. So the primary goals, typically, I want to improve quality of life. Before, as a medical physician, you're kind of like trained to identify a problem, give it a diagnosis, and here's the therapy. And you think that by giving this therapy, you're going to improve everybody's life. Well, in certain cases, as we'll probably get into here in a little bit as I'm talking and as we discuss a little bit later, sometimes our therapies can actually make the quality of life worse. So you have to be very careful and think about kind of like the lifestyle and the goals of the family and the patient. course, in Duchenne's and throughout their different stages, you have to correctly identify what the problem is. For instance, as we were just talking about the eating issues, there actually can be a big, large anxiety component over that too. That if someone's having this pressure put on them to try to get more nutrition in and things, then they start to develop what we call like a globus sensation. So being able to identify when a patient has just even problems pooping, everybody thinks like, okay, if I have a bowel movement, I'm not constipated. That's not necessarily the case. And the same with eating. I'm eating, I can swallow easily, I must be doing fine. Again, there are tools that we use to help try to determine questions, to determine if there's a problem. And then you have to be able to identify the problems that are often associated with muscular dystrophy, Duchenne's or Becker's. And again, this depends upon the stage. Constipation in the early onset is typically more due to the behavioral issues. When I get a 9-year-old who's still walking and has maybe some bowel issues, some incontinence, the problems are a lot different than, say, a 21, 22-year-old who's non-ambulatory. You've got to be able to kind of know how things change and progress. So our goals then is to actually, as I said, address the GI disorder, but do it in a way that can help improve the quality of life. And then the other thing that we do, knowing how things progress, is I always try to be proactive. I'd rather get to you earlier before the problems really develop. For instance, watching that weight over time, because it's really kind of ironic, as a lot of the young men are on steroids, they're told to really minimize your weight, really minimize your weight. You're gaining too much weight. And then around maybe as they start to lose the ability to walk, start to lose the function of their arms, I start watching the weight at every visit coming in, and I start seeing it trend down. And now they've been told all along, minimize your weight, and then I come in and say, wait a minute, I'm starting to see a problem here. So being able to know when the times to intervene and when to try to avoid the problems with nutrition, as was just discussed, is that we don't want to take away your ability to eat. What I want to do is prevent you to get into a malnourished state that will make your heart failure more pronounced, that will progress your pulmonary problems more, plus would also make it more difficult for you to fight off infections and put you at a higher risk of getting into the hospital. So we want to be able to avoid those things with uses of some kind of supplementation, making sure we're monitoring things closely. And as I said, the therapy and treatment should always be better than what your current state is. For instance, it's very high risk when you're losing muscle mass and you're not able to walk and you're not using your core muscles much that you do develop stool retention. But the last thing you want to do is just put someone on medications to make them poop when they don't have access to a bathroom. So instead of treating a constipation, we talk more of what's going to be our bowel regimen. What's going to allow you to be able to function at school or work, or if you want to go out with your friends or your family to a movie theater and not have to worry about needing to go to the bathroom. So as the example that I was just talking about, just that for that instance, as I said, constipation early on is different than later. 1 out of 4 patients with Duchenne's at all times of their life, 1 out of 4 are known to be constipated and not treated. There was a study done out of Cincinnati where they found half the patients are constipated, 25% of them knew it and were being treated, and 25% had no clue, and neither did their neurologist or anyone else in their clinic at the time. So try to catch it early so that you aren't stressing out the colon and then having the problems when you start to require having a wheelchair, so that we don't have to have the problems with incontinence early on, but to start implementing a bowel regimen right off the bat. So when you're making that transition, we can come up with something that's going to improve your quality of life and prevent a progression of a condition that no one really wants to talk about. No one wants to talk about crap. No one wants to talk about their pooping. Every time I come in and I start asking questions, it just immediately, I can almost get a better response of like, for some of the older ones, like how much alcohol do you drink or what's going on, other things. No one likes to talk about their poop. So, talking about it early, trying to identify those who have a disorder, and then trying to identify, okay, in the next 3-4 years, what can we do to help you make this transition? That's it.
Thanks, Kit. Obviously, eating and pooping all go together, and I'm going to now endow a honorary urologic degree on Mina. But I think that we're all going to try to talk about some of the urologic ideas that we see in young men with Duchenne and Becker. Because, like Ken said, it's really more about quality of life. How can we do things not to make the quality of life worse, but the quality of life better overall? And just, an example that I learned, I think maybe 2 PPMD meetings ago, I was in a group of young adolescents, and I learned from them that there were different kinds of urinals. I'm a physician. I didn't know that there were urinals that were shaped for women, and there were urinals that shaped for men, but in this case, it's much easier to use a urinal that's shaped for a woman if you're in a wheelchair. And it was like a light bulb went off in my head. So anyways, we're going to be using the slides that Dr. Wood provided us, and going to have a conversation about it, I guess.
Yes. Well, thank you. I'm a neurologist and also work with PPMD on the clinical care team. So I see kids with urologic issues all the time, but these are slides from Dr. Wood. I missed my flight, was canceled the other day, so I guess this is paybacks, and now I'm doing urology talk. Urology, neurology, we always have to say URO or NEU, so as per Dr. Wood, the issues that we see often in clinic with children and young boys and men are urgency, so having to go to the bathroom very frequently is common, and then hesitancy, having difficulty starting that initiation of urination. And 16% are dissatisfied with these symptoms. So if you're out, I was talking to Dr. Apcon earlier today, and as a rehab doc with individuals who have spinal cord injury, she too was talking about societal continence, which is not a word I use a lot, but how you regulate going to the bathroom when you're at school or when you're out in public. And so these are issues if you have to go all the time, if you have to really, I have to go and I have to go now, or you get there and you can't go and people are waiting for you. These are all things that impact your life and your desire to go out. Incontinence, so having accidents, up to 37% of individuals, and we see daytime and nighttime incontinence, and so you can imagine this as well. This is a major issue for many neurological issues that we see, but also in this situation where sometimes waiting too long. A child is at school, doesn't want to ask, may not have an aid, or waits too long because they're engaged in things, and then may have an accident. There are a variety of different reasons why this may happen, but incontinence is another issue we see. Oh, did I skip one? No. And then what we can do to intervene sometimes is not ideal either. Having to depend on someone else to take you to the bathroom, having to ask, having to interrupt. Medications can be very helpful, but they also sometimes have side effects, so it's a pros and cons. Is it time for me to start medications at this time? Intermittent catheterization, so actually having a catheter that is placed when you need to go or at certain times of the day, so you're not surprised by having to go. And possibly a suprapubic tube. And so that's a tube that's placed right into the bladder and drains, so you the individual doesn't have to worry about going to the bathroom, isn't surprised by suddenly having to go quickly. So that is a surgical procedure. Dr. Opcon was telling me for some of the individuals she sees with spinal cord, they even do it in the office, but it is a surgical procedure and intervention, but can be very helpful. You know, when do you do that, I think is very individual based, but I think it's important to speak to your clinic team, your neurologist. If you are an older individual and seeing that it's really interrupting your school, your social life, to say, I'm really struggling with this. And they can refer you to urology, who can intervene. They'll look at ultrasound, urodynamics, and do other tests to see if this would be a helpful procedure. So there's a lot of ways to intervene, and that's where I think it's important to know your urologist, to know that they're available for this, and that it can improve the quality of life. Very few data out there. Some have symptoms and many don't have individualized approaches, but I think it's definitely worthwhile seeing a urologist. I was talking to Sue earlier. Years ago, one day in clinic, we had a young man, and he was in his late teens, and he came with his grandparents, and they said, show Dr. Scavino what you have. And he took out a piece of, a little towel, and inside was a big stone. And I said, what is that? And he said, I passed this on Saturday night and I wanted to show you. And it was the beginning of realization that as boys get older, and we started around that time to learn more and more that stones, kidney stones, are an issue. And so proper hydration is really critical. You know, and everyone knows the situation with that. Kids don't want to drink because they don't want to have to go to the bathroom in school, and they don't want to bother someone. And so these are some of the sequelae that we see. So very frequently we end up seeing urology because a stone has been passed. And so it's something to think about and something to be aware of, which we all learned as boys got older and older over time. So good hydration is really important, and I dare to say that not being well hydrated also contributes then to the constipation. And
one thing I would say too is that problems with urinary frequency and having to go all the time, having urinary accidents, one of the first things a urologist is going to screen out is constipation too.
right.
A lot of the young men are referred to me after they've seen the urologist because of the problems urination, because it was constipation causing the problem.
Yeah, so the two are very much together. So hydrating properly, managing constipation, managing good diet and proper swallowing, all try to help those things. And sometimes they are just issues and you need to seek medical attention or surgical intervention. Thank you.
I think you did a fine job. Yeah. You know, I think that one of the things all three of our speakers brought up, and I've brought up as well, this is all about quality of life. Like, we're talking about surgical procedures, there are medications that can help. There are certain things that we can do to our diet that might help us eat better, but it might also help us poop better or more easily. I know that Dr. Williams is taught, and all of us in clinic are focused on chocolate soft serve ice cream. That's what you're going for. All of the young men like to laugh, at me when if Dr. Williams is not in clinic, I usually am the one asking about how they're going to the bathroom. But I think the important thing is, even at the biggest centers, we don't have a urologist in clinic. We don't have a speech therapist sitting there in clinic with us. And I always tell people, wherever you are, if you have questions, ask, because sometimes the people who are coming in to see you aren't going to necessarily ask all the time, have you been pooping normally? Or, I've learned from the cardiologist with some of these new cardiology drugs that there are some young men that know that taking these drugs are going to make them go to the bathroom, but they have to stay hydrated so that they don't have side effects from it. So they're just not drinking anything, so they don't have to interrupt their day to urinate. So there's all kinds of things out there, and I think that we're talking about vesicostomy tubes, we're talking about colostomies, we're talking about all these things that are like major surgical interventions, but we're talking about it here as a quality of life issue. You know, I have a young man with spinal muscular atrophy who went off to college last year, and one of the things that he wanted was a vesicostomy tube so that he didn't have to rely on somebody else helping him go to the bathroom. He could go to the bathroom and put the catheter in and go to the bathroom and not rely, and it gave him a bigger sense of independence. But on the other hand, it's a surgical procedure, and you have to be able to tolerate that type of thing, because there's, you know, other things we have to worry about. So I thought I'm happy to open it up for any questions from the audience. I know that we didn't have a lot of slides, but that was the point, because we wanted to get people's input on your own experiences, things that you could teach us. I do have a whole set of questions here that I can ask if there's crickets in the audience. But you know, there should be no, I mean, I know we're talking about pooping, peeing, and eating, but there's no embarrassing questions. So bring it on. They're ready to answer anything you have. Maybe not as much urologic issues and what those surgeries mean, but you know, I think that again, just focusing on what we can do from a quality of life standpoint to help the young men do what they need to make it easier for parents and grandparents to give that care as well. Do we have any questions in the audience? I think there's microphones. Yes. It's hard to see you because the light is right in our eyes, but.
I have a son, 28-year-old son, who's just recently started having problems with kidney stones, and he's always been really good about keeping himself hydrated. But we were told that just because of their sedentary lifestyle, they're more prone to kidney stones. Is that true? And also, our cardiologist suggested, or the nephrologist suggested taking him off spironolactone because they thought that might be causing the kidney stones, and we really are hesitant to do that. So I was wondering if anybody could comment about that.
It is possible that sedentary lifestyle may cause an increased risk, but it's not the only thing without knowing more of the details and things like that. The questions I would want to know is when you say keeps well hydrated, just exactly what is the volume of hydration? Because what I find with both hydration and eating, particularly when you're talking about someone who has Duchenne's in their mid, late 20s, is that over a period of time, they're taking in less and less. It's very gradual. And that's what we really try to focus on in our clinics, is what is our actual volumes that we're talking about.
He's at least 80 ounces of water a day.
Yeah.
More, maybe,
That's
usually
hydrated.
more.
That's hydrated. Then we would want to take a look at the diet also, like to see if there's certain things in the diet that might make it more prone to
Sodium or?
yeah, well, not just sodium, but calcium and different things. I mean, there's so many other things to go into that. But too bad we don't have urologists here. I don't know of just like that's being a extremely common thing. I mean, maybe other parents can help them with this too.
I mean, we do see it rather frequently. We've had a few kids who there's a family history as well of kidney stones, and then sometimes that predisposes them. But you know, I think some of the supplements that you're on, the sedentary lifestyle, for some kids the hydration isn't as much, but it is something over time we are seeing just in older individuals. When I was, again, talking to Dr. Abcon about it, she has 2 kiddos, older individuals that actually had to have some surgical intervention. So it is something. I can't comment too much with the spironolactone. I think that would be up to the cardiologist and the urologist. Has your son seen a urologist and follows with them? Yeah. And nephrologist? Yeah. So again, risks and benefits of the medication for his heart with the risk of, kidney stones and so on. Probably have to take a look at those. Yeah.
We have some questions over here.
There is a recurring topic in Duchenne mom Facebook groups, and it has to do with urine color. And so a lot of times, somebody will say, oh, this looks like blood in the urine, and someone will comment, well, no, it's just dark and brown, and so it's probably due to muscle breakdown. Can you talk a little bit about that? What should we be
I
really
wish I
worried
had
about?
for you. So in our office, I didn't buy these paintings. They were just pictures that were put up when they renovated. And I call them my P charts because they just have the perfect, there's a white border, yellow coloration, and then inside pictures with light brown and dark brown. So I always say to the kids, this white border is sort of what you'd like your urine to look like, nice and clear. Yellow, I think we've all experienced it when we're dehydrated and haven't had enough to drink that day. But if it looks like Coca-Cola or tea or this brown, that's too much, and then you need to talk to your mom or nurse or seek medical attention because that tells us that, we call it myoglobinuria, that the muscle's breaking down for whatever reason and being spilled into the urine. I've had a few kids with Becker present with actually rhabdomyolysis where their CK level has gone up pretty high and they've had to be hospitalized, given IV fluids to hydrate. For whatever, there's reasons. I haven't seen someone in my clinic, in my practice so far with Duchenne, but it's something we talk about all the time, particularly in the summer. I say if it's a hot day, you're at the pool, you're outdoors, they're playing, they forget to drink, definitely check the urine at the end of the day because, it should be clear. So if you think of a painting, it's what I go to. It's just a framed picture with a clear, like a white border, a yellow. Probably you're on that way of becoming dehydrated. But tea or Coca-Cola is too dark, and you should seek medical attention for increased hydration.
You were talking about posture, and so many of our guys, because they need auxiliary help with one arm, they will lean to one side as they're eating. And you were talking about using a PT to sort of, have a workaround on how to get them to maybe sit up a little. I'm at a loss for what to do with that whole leaning thing. Got any ideas?
I'm glad you brought that up. It is really challenging when you're having upper extremity function changes as well too, because that's what is getting the food to the mouth. So sometimes, and people may have seen the robotic arm. There's also the OBs, a feeding arm that can help as well too. But we all like our independence, right? And want to be able to do it ourselves and not rely on anybody. I more get focused on as long as they're upright as opposed to like lying down and eating Cheetos in bed or something like that. I want gravity to help get the food out of the mouth, into the throat and on down. And so I think side to side I'm a little more forgiving at, but it's very individualized. I'll take the individual and feed them some food that they typically eat, and sort of watch and then brainstorm from there. I did want to go back to the hydration issue too. That pops up for me as well. I look at it, and I'm that nerd that has a urine color chart on the back of my badge, and I show it to patients all the time because I'm thinking about it from a function standpoint. If somebody's dehydrated, is it a swallowing issue or is it something else that's going on? And this is the one thing I love about being part of multidisciplinary clinics is that we all have a investment in this and want to help the individual. So.
Can I jump in here? I think it would be good to have a discussion about, because I'm always eager to hear what other institutions are doing about this. Because when you have someone who's having problems getting hydrated, you got someone who's having problems bringing food to their mouth and things. Because I'll get called always by someone to consider a G-tube after the kid is completely malnourished and looks like Skeletor. So one of the things we do at our institute is I start trying to follow those things. What do you guys do? I mean, what's the criteria of when you start, like, look, if you're starting to have problems feeding yourself, and if you're having problems with endurance and those things, do you guys have sort of like criteria in your clinic when you start talking about a G2? Because the first thing I'll tell people is, if you get my experience, if you get a G2 early, you'll actually preserve being able to eat by mouth longer. It's not the other way around that you've now lost the ability. But anyway, I was curious, what do you guys do?
Yeah, I agree. We monitor weight, and as long as weight is steady in people that have already achieved like their adult size, right?
Yeah.
You know, that's our sort of quick and dirty, I like to say, of if they're getting enough nutrition. And I'm fortunate to work with a dietitian in both my pediatric and adult clinics that I'm in, and so I often will go in with them and we'll look at that piece. And then we're also assessing that upper extremity function and how, you know, whether the family's helping feed and how long meals are taking, all of that.
Yeah.
It all goes in together, yeah.
I think too, we definitely will look at the weight carefully. I think if they're choking or reporting choking more, having issues, avoiding foods, they've come into the ER with an episode. Obviously, we like to avoid that way beforehand. But if we see that, I think the child is or the individual is more motivated to do something.
Yeah,
more.
I mean, but I see choking with food and the actual end stages of problems of swallowing not as common as I see someone who's gradually losing weight over the last 2 years, and then they get to a certain point and it's like they fall off a cliff. Yeah. Trying to keep them from falling off that cliff is what I would like to try to encourage people to do. Do you guys have a way of doing that?
We have a specific criteria that we'll use. I think we look at the weight, and if we see that trajectory that it's just continuing to go down, they may say it takes us so long to eat. I'm not eating at school because even though no one will feed me. Those other areas regarding meals and the joy of eating, then.
Do you have a conversation with the families early on though, when you start to see that weight going down and saying, look, not right now, but we're starting to see some trends. As I was saying earlier in my slides, one of the things that as a GI doctor now I've learned is try to avoid the problem. Don't wait until. Because once you become in severely malnourished state, you're going to have rapid loss of muscle, and you're going to have more cardiomyopathy, more trouble breathing, and actually just trouble thinking and concentrating.
So I think like a lot of the interventions, and this is just my perspective, they sound worse to families and individuals than perhaps they are. We just recently went through this with someone in our ICU, and you know, once if we go to that level and they get it, they're happy that maybe they have that. But the idea of having a surgical intervention, not being able to perhaps sit down and have the same food as your family, for a lot of people, it takes a while because I think the acceptance that you're getting food tube. And
I don't want to cut people off because I think this is a great conversation, but there's a line forming at the different microphones.
Sorry, I couldn't see if people were just.
But I just was going to add that I do think that the conversation should happen early. And that, you know, you should, if you are thinking about, like, is this something that my son needs, ask your practitioners in clinic. You know, I found that some people don't necessarily bring it up, and that's why it goes for a couple of years. But go ahead.
Sure, thank you. First, I want to say thank you all for taking an interest in our boys. It means a lot to us. I noticed under the urinary topic that there wasn't, under the treatment category, the suggestion of an external catheter. We jumped straight to internal catheterization or a suprapubic tube. Yeah. And I wondered, my son uses Men's Liberty, which has been way more better than a condom catheter, but at the same time, I'm open to other options if you think that.
I know I think for some reason I feel like the trend, at least that I've seen in some of the kids, has been a little bit to use less the external, but that doesn't mean, because when I was trained we did use Texas catheters and other types of external catheters. Again, in my discussion with Sue Apcon this morning, telling her I was doing this, You know, sometimes the fit might not be right for some people, and they may not stay on. There may be difficulty getting them on, and so I think it's an option. Sometimes it may be easier to just use a urinal itself intermittently, or if you're at a certain point, the suprapubic. But I think it's definitely an option, and everybody's comfortable with different things.
Yeah.
So.
I was going to add the same thing. I think anatomy makes a big difference when you're looking at a product out on the market that will fit appropriately and not leak and cause more problems in the end. You know, I think urologists use the internal catheters a lot more too, like, because it's something that you can plan. Like, you know, you can cath at 9 a.m., 12 p.m., 2 p.m., like, and prevent the need to like rush to the bathroom kind of thing. And I know in other disease processes we do that so that we can empty the bladder and not get urinary tract infections, but doing an internal catheter does have a risk of urinary tract infections where the external catheters don't. But I feel like in these young men with Duchenne, it's more finding the actual device that fits appropriately and does what it's supposed to do, I guess.
Thank you.
I think too, I noticed that too in those slides, that there wasn't anything external. And in one of the conferences I was at just recently, a mom presented that she came up with her own home kind of catheter system where she created zippers in the leg where her son was still able to pull a tube in, put it over the penis and was able to pee, and the tube went to a catch at the bottom of his wheelchair. So
I love it.
I think, I'll be honest with you, I think there's like a great opportunity for like a whole cottage industry for addressing how do you fit the quality of life at that stage that works for you.
Thank you.
As I said earlier, a lot of people are so afraid of doing the surgeries, but all I gotta say is, I've been around this for 20 years. These surgeries are not horrible, but I also want to respect the wishes of families and the kids, and we need to come up with sometimes, all right, here's your other options.
I'm in a unique situation where I have a son with spina bifida, and we do the intermittent cathing. And then my son with Duchenne, we do the external, and I can tell you hands down, the external is way better. But again, the fit, like you said, is a problem sometimes.
Yeah.
But I haven't left the microphone because I just have a very quick question about the color of the urine. Are you talking those white, yellow, brown? Is that once it's hit the toilet and it's been diluted with water, or is that in a in a urinal, you know, where it hasn't been diluted yet?
I would say that I always tell my patients if it hits the water, it should be clear.
Yep.
And that means you're well hydrated. If it hits the water and it has any yellow to it, it just means you're not as hydrated as we'd like you to be. But if it's dark, the hard part is that dark yellow. If it's brown or cola colored or things like that, it's definitely something that you should pick up the phone and talk to somebody about.
Okay, thank you.
So that's why even little guys, we say, check your pee-pee when you after gym or after class. Always tell them even to take a look at it, because even the color in the toilet itself is very important.
She may have been next.
Go ahead.
How much water is enough, like for a day? Like Mama is pushing always, drink some more. So what is the limit?
I think the traditional number is 64 ounces. So 3 bottles of water, like plastic bottles of water, 3 32-ounce bottles of water is like what is like a minimum.
Okay, is it not based on age or weight? Just
you're correct. I mean,
For the very small,
Yeah.
that's a tricky dose. That's a lot. But once they're able to tolerate more, that's usually what we recommend, the 64 ounces.
okay, thank you.
and that goes for everybody in the room too. You should all be drinking 64 ounces.
Hi, I was just going to speak up. I'm Laura Case, I'm a PT at Duke, and I was going to speak up about the eating issue in terms of self-feeding. And I do think all the arm support things are important to know about and to try out and all. But one of the easiest things at first is just an elevated desk height can make it easier to feed yourself without leaning to one side. So that's one thing. But I think you should hopefully be able to get some support from your PTs and your OTs for those kinds of things. And even for different catheters and using them, OTs can be really helpful in terms of somebody's hand function. So that, and then I was also going to support very much the concept that you talk about the option of a G-tube just well before it's needed, just and to make sure people know that it doesn't mean that you can't be eating by mouth.
Yeah.
So yeah.
No, I always bring it up. It's an earring in a weird spot. You can go swimming with it. You can do anything with it. Like, it comes out, you put it back in. But it's getting past that point of it's a foreign body and you're doing something to your body that's not the norm, I guess.
Right, but I think, again, the way you talk sounds so nice and gentle, so I'm sure you do well. But just so people know it's an option.
Yeah.
Nothing you need now, but just to know if it ever comes up, so it's not brand new when it's an emergency.
Hi, I'm not sure if this is the last question to ask, but it's about nutrition. As for the Duchenne kids, like my son, they're taking steroid. They will feel hungry more easily. So I was trying to limit his intake of high sugar content foods and also try to control the calorie intake. So if there's a guideline where the parents can see, like regarding the kids, maybe based on their weight, how much calories can they eat, like, and the macros, like how much protein, how much like carbohydrate, and how much fat. And also, like if we add supplements like fish oil to it, does it change like how many calories should he intake daily? Thank you.
I think that's going to be a really hard question for us to answer from a panel. I mean, there's lots of guidelines, and at your clinic, the dietitian should be able to answer all those questions. And I know that there's dietitians here. I don't know if PPMD has specific caloric intake guidelines.
It's hard to know for Duchenne kids, quite honestly. We don't really know, because as you start to lose muscle mass, when that's your biggest part of your caloric intake sometimes, or your need for how much to actually give. So a lot of times it takes kind of an estimation and then follow-up. And it also really varies among age and activity and things. Your best person to answer that question is going to be a dietitian.
I think the other important thing too is, as you become non-ambulatory and you're not moving as many muscles, you don't actually need as many calories, but you still need that nutrition. The fact that you're cutting sugar out is absolutely great. I need to cut sugar out as well. But there's so much sugar in all of our things that you don't need to add extra sugar. So that's a really good place to start. I've always been taught, like, diet, like, we think, if I say diet, you think I'm trying to lose weight. Well, diet is just what we eat. We all have a diet, and we should just eat healthier. And I don't think boys with Duchenne should be any different. But to get those specific, like, calories, it's really dependent on height and, like Ken said, how active they are, and there's all sorts of factors that weigh in there.
Yes, because I just don't want to give like not enough, and in the other hand, I don't want to give too much. So,
And I would also talk to your team too about the supplements. I don't think there's any major problems with fish oils and things like that. Those are good fats, but there are lots of people who use all kinds of complementary and alternative medicine and herbal therapies and things like that, and they do interact with many medications. So it's always a good idea when you're adding supplements for whatever reason, just to double check that it doesn't interact with the heart medicine that you're on or one of the other medicines that they might take. Maybe it inhibits something, so that the herbal won't work because they interact.
Okay, thank you for the advice.
One of the questions I wanted to ask too that you had brought up was about brushing your teeth. Yes. And you said that you get that question a lot.
I do. I am very passionate about oral hygiene, and It surprised me the first few times I would ask people how often they would brush their teeth. How many people would tell me once a week or maybe a couple times a week. I had a clinic full of them this week, actually. It was quite shocking, but oral hygiene's super important, and the newer literature is really showing that even if you're eating solely by a feeding tube, keeping bacteria down in your mouth is really important for pulmonary health. And you know, so I often work very closely with the respiratory therapists and pulmonologists to help kind of brainstorm how else can we get them to clean their mouth so that they can keep those lungs healthy. So.
Great. Go ahead. Oh, sorry. It's hard to see on this side.
In the GI talk, you talked about some of the associated problems changing over time.
Yeah.
And so when my son was little, it was pretty apparent that the accidents we were having were associated with just more behavior and being involved in something and not wanting to stop or not. But he's older now, and he's dealing with urgency and he's dealing with other things, but he still has issues with behavior and whatnot. So my question is, we had things fixed for a long time through behavior modification, and now we're dealing with these issues again. And is there a good way to know if I'm dealing with a change in his body physically, and so therefore he's actually having a problem with the functionality of his body, as opposed to just his not willing to pay attention?
If it's on extremes, yes. If he has a history of passing very large stools, I always ask my parents, is your child, especially in the younger age, I'll ask, has your kid ever passed what I call a holy cow bowel movement? Where basically you take a look at it and you go, holy cow, how'd that get out of you, kid? If that's the case. And there was a study done by Ajay Cole and people at Cincinnati, the most predictive sign of constipation in the Duchenne group that they found in their study was large caliber stools, very large stools, the holy cow bowel movements. The problem there is, and for my work in autism, which actually has transferred a lot to the kids with Duchenne's, and I would suspect with your son, is a lot of the sensory issues, behavioral issues, cognitive issues that go along with it. It's just different, and they are more prone to having constipation. When you have constipation chronically over time, and you're having those holy cow ones, yeah, you can cause stretching and changes in the colon. In the Duchenne group, so early on, I would say it would be more like autistic-like behaviors that was going on with your son. If he's in a wheelchair now and having issues, it switches. Probably those are contributing to it, but it also probably is getting a little bit more of a problem of maybe that he has a very dilated rectum, maybe he's very not wanting to let people know because it's harder to get to the toilet, and things like that. That approach, once they're at that stage, there needs to be more of a discussion of, all right, what we're going to do to help prevent you from having accidents, and what we're going to do to help so that you can be more independent and can be more active. So you don't have to worry about, if I had one young man that when he didn't want to go to restaurants because the food at restaurants made him want to poop more. It's greasier foods, higher fat. It just affected him harder, so he didn't want to go out. So that's the transition I'm talking about. Early on, behavioral, and we want to try to prevent the dilation that occurs. Later on, it's going to really be a discussion of what can we do to try to keep you from having accidents. Does that help any?
Would anybody on the panel be able to answer whether or not urination accidents become a problem with the muscles as they get older?
The thing is, if there's constipation, that can affect, the bladder too. So the two can go hand in hand. So if that's becoming more of an issue increased accidents or frequency. Again, a urologist can tell, they can do ultrasound and something called urodynamic studies, where they can tell what's the bladder like. And over time, they can even check that to see if there is a change. So I would say probably to know for sure. It's hard to say. There's so many factors that go into it. But asking your clinic if he hasn't seen a urologist already for an evaluation if the accidents are starting to come back.
Okay.
Now, later on too, you may not have the really big bowel movements. Getting a simple x-ray will let you know if you have a large amount of stool there. And if you have a large amount of stool in there, they will not do any urological studies. It's constipation first.
The last x-ray was okay.
Yeah. It's hard for me to say without seeing it. So.
Yeah. I was just say we're more than available to stay. It is 4:58, and I know that the buses and things are going to the aquarium at 5 to 6, so I don't want people to feel like you're stuck in here. But we're happy to answer some more questions as well.
Okay, I'll try to make it quick. So we've got constipation mostly under control. We've got the chocolate soft serve, regular schedule, but still suffering from hemorrhoids. And over-the-counter remedies don't really seem to be helping. And, it's not comfortable. It's kind of a quality of life issue. It's not extreme, but I'd prefer that he didn't have to live with that. Any thoughts on what we should do? He doesn't see a GI doctor regularly, just the other core specialists, and I think we're going to add a GI just to have someone in his circle. But thoughts on what to do about hemorrhoids for a wheelchair user?
I was going to say, is he in a wheelchair?
Yes.
Be glad to talk to you more in depth, but a GI doctor, one, to really make sure it is under control, and two, outside of the over-the-counter, there is some lidocaine, there is a couple of prescription things, but it's more of an issue of straining, and once you've got them, it's not real easy to deal with, but there are options to try to keep rectum decompressed, and there are other even surgical options.
Is that something that you recommend in Duchenne? Because that's the other thing I'm thinking. Is it not a significant enough of an issue? Is it something we should just live with? Or
again, without knowing how much it's impacting his life, what your bowel regimen's like right now, it's hard for me to answer that specifically. But as for surgeries, is that what you're asking me, if I recommend surgeries?
I guess so, yeah.
I recommend colostomies in a lot of my young men. And I know that sounds really horrible, but in other conditions, such as spina bifida, the lady we're talking about, we have found that colostomies can really improve the quality of life. It just depends upon how significant cardiac and pulmonary function is at those times. That would be, there are maybe some surgical for hemorrhoids, but you've got to be able to take off the pressure from the rectum a lot of times, and sometimes in someone in a wheelchair, a colostomy I think is a very valuable option.
I just got the hook from Rachel.
If I had one, I would
She's got
use
the
it.
mic too. So.
I do have the mic. All right, unfortunately, we do have to wrap. We are on a pretty strict timeline with our online viewers too. So I would encourage you, if you have questions, I'm going to go ahead and volunteer our speakers. Just come and get them afterwards. They'll talk to you. They're all wonderful. I can vouch for them. They're the best. Thank you, everybody, for joining us. This was a wonderful panel. We really appreciate you staying. We appreciate our speakers for talking about this really important topic, and we're excited to continue to dig in and learn more. I know we've got some good projects kind of coming down the pike. So at this point, go ahead and we're going to wrap. You can go out if you're headed to the aquarium and grab your snack bag. You are on your own for dinner. Make sure that you enter the aquarium between 5 and 6 to make sure that you get that free entry, and then you can stay until 7:30. There are no buses. I'm so sorry. So 15-minute walk, 5-minute train ride, $5 a person if you want to do the train. And what time do we start in the morning? Breakfast tomorrow morning is at 7:30. Again, we do have several different breakfast breakouts. Check your app so that you know which one that you want to go to and where it is. And we start the day with a gene therapy town hall at 9 a.m. in this room. All right, thanks everybody.